everyone, I'm Fola. Welcome to the second episode of the Diversifying Research Podcast. This is a podcast where we amplify the voices of underrepresented individuals who are either involved in research themselves or engage other marginalized groups in research. Over the course of this limited podcast series, we will critically consider how to improve the inclusion of underrepresented voices in research. During this episode, we're joined by Ollivierre, who is the Patient, Public and Professional Involvement Lead at Imperial College Health Partners. Over the course of this episode, I'm going to speak to Kay about her career journey, taking a whole systems approach towards improving diversity and challenging health inequalities, and digital inclusion and exclusion. Hello, Kay. How are you?
I'm really well, Fola. Thank you very much for inviting me to this podcast. I feel very special. How are you today?
You are special. I'm fine, thank you. And thanks for joining me.
You're welcome.
Could you please introduce yourself to our listeners?
Right, yes. So as you've said, I'm Kay Ollivierre. My name's actually Caritha, but everyone at work calls me Kay. So at the moment, I'm the lead for patient, public and professional involvement, which is kind of an involvement lead for the organisation. And Imperial College kind of occupy a unique space between a kind of a management consultancy and a partnership organisation for North West London healthcare organisations. We're also the academic health science network for North West London. There are 3 in London and 15 across the country. However, in terms of me personally, it's important for me to mention that I'm a naturopath. The opinions for this podcast are purely my own and based on my own experiences.
Amazing. And why did you decide to get into naturopathy?
Oh, that's a good question. I've always been very much into health and fitness and understanding, why the body does, why it does this and why people get ill. And I probably think it's over the last maybe 5 years that I got into naturopathic medicine. I'm also studying at the College for Naturopathic Medicine in King's Cross. It's a 3-year degree course. I've done a year of biomedicine, and for the last 2 years, it's very practical, hands-on understanding, how the body works, trying to almost understand what happens to people when they get ill, but not just about the symptoms, but actually finding out why they have the symptoms in the first place, looking at the whole body and almost diagnosing from what people feel and understand where the illness has stemmed from.
That seems like a really useful degree. And I'm aware that you worked in finance for a number of years and then moved into the health sector. Can you speak a bit about that transition and why you were motivated to work within health rather than finance?
That's really interesting, actually. I kind of started off in international banking, but it was more or less on the human resources side. I became a very young human resources manager way back in the early 80s. That just gives you my age, really, doesn't it? And I worked internationally for a while. And then I moved as my career developed, and I spent 25 years in international banking, which was a long time. The last 5 years was as leading health, equality and diversity within the banking system. And that kind of opened my eyes to a lot of inequalities that were going on within the area of not just health, but also financial institutions, and how if you were a black and ethnic minority organisation, it was more difficult for you to get finance and understand how your organisation should work financially. And so it was very interesting to move from the human resources side within banking. When I left in 1996, I then almost fell into working locally when I came back to the UK and into an organisation and a trust, which was almost like, well, I don't really want to go back into the city. I want to work locally. So I just fell into as an HR manager within my local trust hospital. And then I kind of developed a kind of an interest really in understanding different communities, how they operated, how they access healthcare. And that then drove the next 10 years of my career, really, working in the PCTs before they changed to CCGs, worked in commissioning, worked in community services. So I had a really good understanding of how the healthcare system worked, particularly when I worked for the Strategic Health Authority and helped them manage Shaping a Healthier Future, which is a massive reorganisation of services across northwest London, which really opened my eyes to a lot of health inequalities at that time. So my current role was kind of a combination of all those years of experience, which I now bring hopefully to this role within Imperial College Health Partners.
That's really amazing. And for our listeners who don't know what PCPs or CCGs are, what are they?
Right. So PCTs, well, I can't remember what they used to call them now, but they were the commissioning organisations before CCGs, and they decided to kind of strip out a lot of the middle management across the system and went towards commissioning groups instead of these very localised commissioning organisations. They sort of became much larger, and that's when they turned into commissioning groups, CCGs. Yeah, I can't remember exactly what the term means, but we now have a lot fewer CCGs than we had 10 years ago. But, the commissioning groups are still within the system now, and they are part of our partnership approach to how we manage healthcare. And they are commissioners to the trusts who then decide what services are commissioned for the population that they serve, how the money gets transferred to hospitals and community services. So that's what the commissioners do. They buy services for their local population.
Okay, that's really useful context and a really great explanation. An important reason I invited you onto the podcast is because you're a massive proponent of the whole systems approach, which is very useful when thinking about how to systematically empower marginalized communities and improve diversity. Could you elaborate on what the whole systems approach actually entails?
That's an interesting question. It kind of depends who you ask, really. Systems leaders across the health and care system will tell you it's just a combination of different techniques, different methodologies, different organisations maybe coming together. We now have integrated systems, which is really supposed to be integrating health and social care and other statutory organisations to really support the communities that we serve. There's a big drive now for integrated care, which is kind of what the whole systems approach should be looking at. But for me personally, it's really about systems leaders, management structures, from bottom up and top down, really understanding how they can serve their populations. But it's about being inquisitive, being interested, listening, and understanding what matters to people and bringing the right people around the table in an equitable way, and having conversations about what does it mean for you and what can we do to make sure you receive the outcomes that matter to you, and not departmentalizing people into disparate parts of the body. But your mind and your body, as we all now know, are inextricably linked. Far too long, mental health and physical health were miles apart in terms of how we manage people's care. But in terms of that whole systems approach, for me, it actually means really being inquisitive about that whole person and how all of the systems need to speak to each other to manage a person or a community's care in a way that dovetails together.
Yeah, that holistic approach definitely seems a lot better than having different silos. And how do you think the whole systems approach can be applied to diversifying research and challenging current health inequalities?
That's an interesting question. Well, across northwest London, we need to own the challenge of inequalities and focus our time and resources on improving what matters most to people. It goes back to a bit like the holistic approach. People, professionals living or working in northwest London, be interested in the health and well-being of the person sitting in front of you. understand the whole person, not just what's ailing them. The NHS Confed has pulled out a report this week about health inequalities in our system and how they have been exacerbated by COVID. COVID has given us a fantastic opportunity to really understand now what matters to people. In challenging health inequalities, we need to admit that there is a problem in the first place. And I think if we continue to manage healthcare and systems as we have been doing, it's never going to reduce health inequalities. And so what we do need to do is to identify, what do we mean by health inequalities? What does it mean for the system? What does it mean for individuals? What it means for communities that access our services? And until we start having those honest and open conversations, we're never really going to be able to challenge something that's quite difficult to overcome, which is those health inequalities that, again, as have been increasing year on year. So I'm not sure if I've answered your question, but for me, it's about starting and understanding that there is a problem and start internally. I think, it's almost like going back to how you co-design a great service. You bring your people together internally, understand how inequalities happen internally, what the culture, the norms are for people working in the system. People in the system are drawn from the wider society. So why do we think that it's a utopia? People are going to come with their own views, their own biases, their own views on how people should receive and what they deserve. So I don't see why healthcare should be any different. We need to understand that intrinsically and then tackle it by understanding how people feel, why they don't want to come into the system following COVID, why they feel fearful, why they now distrust the service. Once we can start having those conversations, then the system can understand, okay, so what could the solution potentially be to start driving down these health inequalities? It's not new to understand individual requirements for health. We'll go back to this element of choice, which is very, very old hat. Look at the individual in front of you. Understand what they want as an outcome, which might not be what we believe is an outcome until we ask that question.
That's definitely important. And what do you think the role of researchers is when it comes to basically challenging such systems and ensuring that communities are empowered and their voices are being taken into account?
I would start by talking about my experiences about how particularly BAME communities understand what research actually means in the first place. There's a real fear of research because there's historical legacies of researchers in the past not actually having BAME communities' best interests at heart. And therefore it has left a very sort of fearful, almost like, oh no, I'm not interested, don't want to get involved in this. So I think the first thing to do is for researchers to really understand, again, what those barriers to research are for some communities and be understanding of that and almost bring them in, enable their understanding that this is a benefit for their communities. This will really help to understand some of those real inequalities that happen in their community to help the researchers fund research projects specifically to support the outcomes of these communities. But until you really get down to the DNA of why they are fearful to come forward and research, you're never going to have them in sufficient numbers, particularly bringing in healthy BAME communities to do research projects, because that's really what we're looking for. We're not always looking for people who have diseases, but healthy people as well. So I think it's a big and a huge communications exercise. Within ICHP, we have a Discover Now database, and the database, and we have people who go recruiting people from all different communities to take part in research. So they sign up on the database across Northwest London, and they can then have a view on whether they actually want to take part in research. It's all unidentified data that we hold on them. And then the researchers come through us as an organisation to contact individuals who have signed up to the research database and ask them whether they'd be happy to take part in the research. And it could be simple things as giving blood, answering a questionnaire, or physically being involved in some sort of research for drugs trials or whatever it might be. So it covers a whole area of research. But I think what researchers need to do in answer to your question is to understand the communities first, understand why there's a reticence for coming into doing research, and then trying to capture a groundswell of people signing up to research, and then making sure the research focuses on the benefits for those communities by enabling their understanding as to how the outcomes will be shared amongst clinicians, the communities, and the patients in the community that we serve.
So that's really good advice, and that sort of moves us nicely into the amazing work you're doing with Community Voices in North West London. Could you explain what the organisation does and why you decided to join the group?
Community Voices, that's really interesting again, yeah. So it was at the early stages of the pandemic back in March, and most of the North West London organisations were almost commissioned to work across what we called the Gold Command work, which was to focus on where we could support the COVID efforts. So all of our standard projects were stood down in preference for supporting all of our trusts and commissioning groups to mitigate some of the outputs of what COVID was doing. So in terms of understanding what happened in care homes, understanding in terms of, people leaving hospital and going to the Nightingale or going home. So it's really looking at the whole map of what was going on during COVID. And Imperial College were commissioned to work with our partners to ensure that we helped with the effort in terms of resources. So because our normal projects were stood down, I volunteered to work for the out-of-hospital care in terms of COVID. It dawned on me very early on that within the organisation we're doing some phenomenal stuff, really having some great data, identifying all the great dashboards that we were supporting our systems partners to understand, the transition of patients from one care to the other care. Whilst I was supporting that effort, I was also continuing my engagement work and understanding, okay, so what's actually happening external to the organisations, what's happening on the ground, what's happening with the patients, what they were saying, how they were feeling, how they were managing lockdown. And it dawned on me very early on that actually there were some communities that were actually being impacted by COVID much more than some communities. And it happened to be the Black and ethnic minority communities. For whatever reason, at that stage, I didn't know why. It was really concerning because it wasn't only impacting people that I was engaging with, it was also impacting on my own family, my own friends and my friends' family. It was like this very two parts of me. One part was we're doing some phenomenal work within the organisation, looking at all the data. And on the other hand, for me, it was all about conversations about the distrust that was happening, people dying disproportionately and not understanding why they couldn't see their loved ones. And so all of this was kind of making me feel quite sad. And so I couldn't quite marry the two sides of my role. So what tended to happen was I started to speak to different advocates within the community. I started speaking to my colleagues at the CCG. And the CCG started to have very similar conversations with community leaders, with staff who were working in the trusts, who were also being impacted by COVID. And so it kind of started to form this alliance of understanding and sharing the horrors and sharing the stories. And for me personally, it felt like a safe haven. It felt like somewhere that I could go and speak to people that understood how I was feeling, because they had similar experiences as to what they were hearing and what they were seeing. I wasn't getting that within the structures of my organisation. You know, I had my sister who's a frontline nurse at one of our local hospitals. And my sister is as tough as old boots. And I had her on the phone crying because of what was going on in her hospital. I thought, my God, this must be really bad for my sister to feel like that. Then my brother got COVID, who's a bus driver. And so my experience was so different from my colleagues within my organisation who didn't know anybody who was impacted by COVID, which for me was really... How comes I know all of these people and you feel so distant from what was actually going on the ground, but still you're supporting by all of these efforts? So Community Voices, in a nutshell, was born out of people coming together, both BME staff, you know, communications people, equality and diversity leaders, nurses, doctors, community leaders, coming together to say, look, what can we do about this? Then we started to have conversations with community people, with patients who are impacted by COVID. And that then gave us all of this phenomenal insights and this great data. Then we started to formalise these interviews, formalising our approach. You know, we almost pulled together a team of people to go out and find people to talk to, because the system almost wasn't really listening and wasn't really hearing what was going on outside the walls of their organisations. But what Community Voices were doing was bringing together some real impactful insights on why people started to feel this distrust with the service. On the one hand, we were going out every Thursday and clapping for our NHS like I was for my sister and all the other people working on the front line. And on the other hand, you've got people in the community and patients saying, well, my loved one went into hospital yesterday, they've died, and no one's given me any reason. They're just saying it's COVID. And then all these reports started happening about BME people, their lifestyle, their weight, their diabetes, their long-term conditions was the reason why all of this was happening. And I thought, really? So that's how Community Voices started. I call it, it's not an organisation as such, it's a people empowered group made up of people who have very, very similar backgrounds and views about having a different conversation with the system. The system likes to dictate the terms of how they engage. It's driven by their agenda, driven about perhaps what keeps the chief executive awake at night, as opposed to what keeps the patients awake at night. Because actually, they need to start driving the agenda. They need to take back the control of what the system does on their behalf so that we all can actually have the outcomes that people actually want to see. That's a really long answer, but really had to be said because I'm really passionate about it.
No, and I'm glad that you actually said what you just did, because they seem to be doing such exceptional work, and I love the fact that they seem to fully embody the whole notion of a whole systems approach and just trying to empower local people as well. I'm aware that you've been doing a lot of work around improving digital inclusion in Northwest London, and Imperial College Health Partners is part of the Northwest London Health and Care Partnership. And there was recently a workshop on digital inclusion in order to inform strategies to reduce health inequalities in Northwest London. And as part of the workshop, there was a shared definition of digital inclusion and exclusion that were established from the perspective of the local community. So can you tell us what the definitions of digital inclusion and exclusion that were decided on?
Yes. Let me just firstly give you some context to the workshop that happened last Friday. This workshop came about by conversation that I personally had about being asked to do a diversity and digital inclusion webinar on behalf of the Academic Health Science Network Diversity and Oversight Group. So I know quite a bit about equality and diversity, but the digital space for me was a misnomer. I didn't know very much about digital. It's not my area of expertise. But simply by having a conversation with a few people from Community Voices demonstrated to me that there's a real issue out there, which COVID has really shone a light on. Because of COVID, lots of people couldn't come into the health and care system. So a lot of the care was driven through online consultations. However, a lot of the people who we were talking to through the Community Voices were unable to access those services because they didn't have either the know-how or the hardware to access those services. Most people have a mobile phone, so I think 111 came into their own at that time. But even then, there was still this barrier. So the outcome of the webinar was that, again, it goes back to very simple service requirements. It's about having a conversation. It's about understanding what those barriers are, bringing the right people around the table to have conversations with the digital experts, with the systems leaders, so that they really understand what is the task to be tackled here. There's a huge, huge department looking at digital inclusion across the system. But locally and on the ground, there's still not the understanding as to what is it that people need to enable them to reduce the exclusion in that digital space. And during COVID, obviously, we know systems had to bring in all these digital solutions at speed, and rightly so, because we had to have some sort of interface for patients. But herein lies the issue. It drove up more exclusion and more inequality. So, in answer to your question, last Friday's workshop, this is how things happen in terms of having that conversation. It generated a groundswell of interest following that conversation. Members of the CCG who were also looking at digital exclusion, there were other organisations that were interested, lots of clinicians were interested, because all organisations now have a part to play in reducing the digital inclusion, because this is the way we are going towards. This is not going to change. This is not going to go back to normal. So as a result, I spoke to my colleagues within Imperial College. Again, we had a remit to look at digital inclusion. So as a result, we all agreed with the CCG to facilitate a workshop for all of the people to come together to start having a conversation about what's the issue that we are trying to tackle here. What is it that we need to do to mitigate digital exclusion? So as a result of pulling the invitations out for this workshop across a diverse range of clinicians, systems leaders, community leaders, etc., we had nearly 100 people sign up to this workshop. I mean, just more than you could ever imagine. So what the system didn't want to do is define what digital inclusion actually means. We've all got to come up with a definition that suits who's ever in this space. But it is really about reducing the barriers for people to access healthcare services through digital means, and that may be a smartphone or a laptop. And we're aware across North West London that not all of our populations are able to access services through that digital means. So if we know that, we've got some real work to be done to remove those barriers. So the workshop for me was all about, let's not jump to, digital tools and techniques before we really understand what is it that people want. Do they want to access services through the digital means, or are we going to offer them a choice of how to access services? So the workshop really said, look, we're not going to dictate the terms of how we engage. We're really going to, this time, like we should do for any good service redesign, is have the right people around the table and start having the conversations. This is not new. Digital access to services has been there for many, many years. But what hasn't necessarily happened is that we're not sharing the best practice. There are some really good solutions and some really good pockets of best practice, but then the other side of North West London have no idea what's going on across the other side. So again, it's about sharing best practice, putting all of it on the table, looking also what the community are doing for themselves. The community don't rely wholly and solely on coming into a service. There's phenomenal stuff been done by the Abbey Centre, for instance, in terms of helping different communities access services in an equitable fashion via digital means or otherwise.
Amazing. And I know an aspect of the workshop also looked at the first set of barriers and second set of barriers to digital inclusion to improve how it is understood. Could you explain what these are for our listeners, please?
Yeah, so some of the barriers that came up at the workshop, again, so this is, from the people who attended. So there's things that you would obviously understand, like no laptops, no smartphones, tablet or internet due to poverty. Some families can't afford to have, multiple media in their homes, particularly with children when they were doing their homework, through a smartphone or a laptop. That doesn't leave a lot of accessibility for maybe parents and other members of that family to access health and care services. So again, the hardware is clearly a barrier. E-learning is difficult for some people. Without good support, often one-to-ones is needed in terms of helping people to understand how to use that digital tool to access that service. Language barriers and the use of IT equipment, not enough equipment for families, as I've just mentioned. So we then come on to the vulnerability. Older people cannot access online services or activities. People living with severe mental health illness find it challenging to access online services and activities. So again, this for me goes back to this holistic approach. Don't jump to the digital solution, the kit, the hardware, the software, before we have an understanding of the needs and the quality of care that people are receiving as a result of remote consultations, for instance. We need to ensure that we ask the right questions before we get into digital solutions. We can't afford for this new era of phenomenal digital kit to be another barrier to accessing services equitable. All it's going to do is exacerbate another layer of health inequalities.
And what are some of the exemplary initiatives which you're aware of that are being carried out at a national level, but also at a local level, that are good examples of digital inclusion, which organisations and researchers could learn from and incorporate into their practices?
Yeah, there's some phenomenal stuff that the workshop unearthed, actually, which really, really surprised me. And it's done at a local level. And, there is potential to roll it out across North West London, but there are some organisations that provide financial support to community organisations working directly with community to provide IT equipment, training, and one-to-one IT support. Schemes to provide IT equipment and internet for the most deprived community members to be endorsed by organisations, working in collaboration with statutory and the voluntary sector, organisations to maximise the use on resources, and also communities working with grassroots to support community members who are consistently being excluded, especially those who are digitally excluded. It's really almost putting your money where your mouth is. If communities can't afford the hardware, the software, need the support, need the training, then some organisations have decided to take the responsibility to ensure that that is not a barrier to accessing services. Otherwise, it's just going to continue. And there's also stuff that community organisations are doing, like the Abbey Centre, some phenomenal stuff that we heard from the workshop. They collaborate with their corporate partners and communities to recruit volunteers to support the older people with IT skills to access health and wellbeing services as well, and to do their online shopping. So again, it's not just about health, it's about the whole person. Health might be just one element of that person's life, but can they access their library? Can they access doing their shopping online, when they're in lockdown? So there's volunteers through the Abbey Centre going and helping volunteers to be more accessible to what their everyday needs are. And so it's telephone support, emotional support, check-in support for socially isolated older people, delivering food and medicines. There's a craft club, materials for older people who are digitally inactive to create artwork to promote their health and well-being. There's so many things, for, our bilingual volunteers, for instance, and sessional workers provide telephone one-to-one emotional well-being in the BAME communities to reduce the stress and the anxiety of lockdown and COVID. And all of these services, for me, should be commissioned, because these are sorts of things that help people not go into stress, not going to the care system or the health system, but keeps them well at home. So these things need to be recognised as preventing disease and chronic illness by preventing the stress, the anxiety, exacerbating long-term conditions. That is really where my mind that the health service should focus a lot more attention on, is that prevention, as opposed to having people come into the system because they're ill or they're in crisis.
Absolutely. And what do you think researchers could learn from such initiatives?
I think it's, again, for researchers to understand what the community needs, what research needs to be undertaken to enable this to happen much more readily. And I think it's only through research and understanding that you find out what people actually need, where the research needs to be focused on. You've got all this data that says to us, about cancer in BAME communities, prostate, breast cancers. We have the most aggressive cancers. Why do? When you ask cancer research, which has been going for many, many years, why do BAME people have the most aggressive cancers, breast or prostate? They say, well, we don't know. So if you want people from those communities to come into research, these are sorts of things that we're going to ask researchers to give us the responses to. Why did COVID disproportionately impact on BAME communities? We've heard reports about their long-term conditions, but actually it's just about helping your immune system. If I go back to my naturopath head, there should be a lot more done about enabling people's understanding as to how to keep themselves well, how to look after their bodies, how their bodies work, how their immune system works, how their digestive system works, because that's where 70% of your immune system lies. It's in your gut. How many people know that? Not many people. These are sorts of information that we need to share with communities so that they can prevent themselves getting ill in the first place. How we eat, what we eat, when we eat, do we do exercise? Do we try and keep ourselves relatively slim and, reduce our BMI? These are sorts of things that's going to help the BAME communities who are disproportionately impacted by COVID not be impacted by COVID, just in case we have another wave of this pandemic. These are sorts of information that clinicians should be sharing with their patients, not just, this is what you've got, I can prescribe something. Then it's, again, going back to this holistic view of health and care. What is it that you need that prevents you from coming into the service in the first place? Do you eat healthily? Do you do exercise? Do you know how to build up your immune system?
So we've come to the end of the episode. Thank you very much for joining me, Kay. I've learned so much about your career journey, the whole systems approach, community voices and digital inclusion. Is there anything you would like to raise that we haven't spoken about?
I don't think so. I would like, to kind of have these conversations with, systems leaders and clinicians and managers who are doing a phenomenal job, don't get me wrong, but I just feel that we're coming into a new era of healthcare. If we continue doing what we're doing, we're never going to reduce health inequalities. We need to have a sharp look at how we deliver services and how we engage our populations and understanding what matters to them, and then we'll meet the requirements in a very different way, having a very different conversation.
To our listeners, please make sure you tune into our next podcast episode where I'll be speaking to Lizzie about her experiences being involved in health research as a young person. Thank you again, Kay.
Thanks for inviting me. I really do appreciate it. Take care. Bye.